So CRISP is Maryland's Health Information Exchange. We're also the state's regional extension center. We started about 4 years ago as an early cooperation between Johns Hopkins Health System, MedStar Health, University of Maryland Medical System, and Erickson. And we got together to talk about improving the availability of medical records in Maryland, and that evolved over time and coordinated nicely with the federal programs to this point today, where we are now the HIE and the Regional Extension Center for Maryland. So CRISP is responsible for all 5 domains, from governance to operations, technology, sustainability. We have to cover all of that privacy and security approach. We do it in very close coordination with the Maryland Healthcare Commission. They're our partners on almost a daily basis, and the governance structure of CRISP is quite broad. From our stateside participation, the policy board participation, down to the advisory boards we have. So while we're responsible for all of it, we rely heavily on advice, counsel, and guidance of many other stakeholder groups. So I think the most obvious that everyone cites is sustainability. There's no doubt that sustainability is challenging. But I think the way we're approaching it is to think about this statewide infrastructure as an asset and a tool to individual hospitals and IDNs to be used alternatively compared to what they may purchase on their own, and that helps to improve the value proposition. Beyond sustainability, I think generally, and this falls across domains of those 5 areas, is how to get hospitals to put resources towards connectivity to the HIE when there are so many competing programs going on, whether it's meaningful use stage 1, HIPAA work, 4010 to 5010 transition. Those things take the same resources, both people and dollars, and convincing them to pursue HIE connectivity early when it's not a requirement is challenging. In terms of sustainability, we've taken a slightly different tack in Maryland, which is rather than going out and providing all the direct assistance, we've contracted with managed service organizations, so they're actually subrecipients from CRISP who will go out and do the direct assistance work. And our logic there was that we didn't want to create a large not-for-profit consulting company, essentially, that was subsidized with federal dollars and had the endorsement of the state, and to compete with small private companies. So our sustainability is partially based in creating a more vibrant marketplace where there are private companies competing for the business of practices, and they're able to serve the market better long run. Taking a step back very generally, when we think about sustainability, a lot of the white papers or value proposition arguments you'll read will kind of dissect all the various stakeholders and what percentage of value inures to them. And I think while that's helpful in terms of a reference point, it's difficult in terms of getting a participant to sign up to pay fees. Our approach so far has been relying on hospital subscription fees, but in the outer years, knowing that the near-term challenge is to prove that this is a valuable infrastructure to participate in, and charging before we can demonstrate that value would be far too difficult. And so we've got a graduated fee model that relies on hospital subscriptions, but that we're also pursuing other paying participants, whether those are the labs, radiology centers, and transitioning to the payer community. We are funded generally right now, both from the federal dollars, but also the payer community in Maryland through a rate-setting commission process. So the payers are participating through that commission. So I think one of the most challenging components of our work up until this point was going through the technology procurement and really wading through and reading all of those thick responses. What's real and what isn't? What are things that the vendors are working towards versus have in production? And how do you get through what's written in the RFP response versus what they actually have? There's no easy answer, but it's doing deep due diligence, asking the awkward questions about what they have, wanting to see it, and it's also recognizing that no single vendor is going to have everything you want. So it's what are you willing to sacrifice and what aren't you willing to sacrifice in finding a partner, and they really are your partners for the long run. So make sure you can work with them well. We're seeing IDNs, hospital systems pursuing HIE-like connectivity strategies rather than single platform strategies based on the expense and the amount of time of the deployment in the single platform model. So we're seeing those IDNs look at HIE vendors and evaluating their technologies just as we had. It poses both a risk and an opportunity. Deploying a separate HIE infrastructure to serve the purposes of a hospital system directly may be competitive or inconsistent with our approach, and the technical connectivity or the policy approach may be different, and reconciling those could be difficult. The opportunity is associated with reaching a much broader set of participants if we are able to overcome those policy and technical barriers rather than CRISP having to go out and achieve connectivity directly. So where we can leverage networks, that's always in our interest and in the interest of the state, but it's difficult from a technical and policy approach. I think initially what we look at is where are the highest patient touch points for the services that we're going to be deploying early in the health information exchange, and that's obviously at the provider level and mostly in a hospital setting. So at registration touch points, having information throughout the hospital at various entry points, and then expanding that into the labs and radiology locations, into ambulatory provider clinics and practices, but then relying more on the state and more on some of the federal level communication work that's going to evolve. So we definitely see it as a multi-pronged approach, and starting where there's patient touch points is where we're getting kicked off.